Hello, I'm Professor Stephanie Watson from the University of Sydney and head of the cornea unit at the Sydney Eye Hospital. This lecture on dry eye management will address some of the principles needed to manage patients with dry eye successfully. So my approach is to use a step ladder. And what does this mean? Well, basically you assess the disease severity, start treatments, and then reassess, usually after about 6 weeks. The response to treatment will tell you whether you need to move up or down that ladder. Now, where to begin? Well, at the bottom of the ladder, the first thing to do is withdraw preservatives. If you do, you may then need to start unpreserved lubricants. Educate the patient on lid cleaning if they have anterior blepharitis, and how to perform hot massage for meibomian gland disease, which is probably the commonest cause of dry eye disease. Now, in Australia, rosacea is a very common cause of meibomian gland disease. And for patients, if they can identify a trigger that they can avoid, it can really help with their symptoms. I had a patient once who decided to quit coffee, and he started drinking lots of hot chocolates. But unfortunately, chocolate was a trigger for his rosacea, and his meibomian gland disease soon got out of hand. Once he started some massage and avoided the hot chocolates, his symptoms improved. If you need to do more, particularly if there's nocturnal leg ophthalmos, then start some lubricating ointment at night. You may need to move up the ladder by using some topical steroids to treat inflammation and consider some punctal plugs, but make sure you treat concurrent blepharitis first. Next, have a conversation about cosmetics if they're wearing them. There can be some less irritant cosmetics, and the patient may want to be counseled to avoid putting eyeliner on the inner rim of the eyelid, as this can block the meibomian glands. If there's coexistent allergy, and usually you discover this on history by finding out that they suffer with itch, also have a look for a papillary conjunctivitis. If so, you may want to co-treat with some topical antihistamines and mast cell stabilizers. There are a number of formulations of cyclosporin available topically that can be used in some patients, particularly if there's signs of aqueous tear deficiency. And if there's really no response, you may want to move up the ladder to autologous serum drops. But not every patient can have their blood taken for them. Some centres now offer allogeneic serum drops, and this can be an alternative if they're not suitable for autologous collection. Now, the environment. Often the environment can exacerbate or produce dry eye. At the moment, people are spending a lot of time on screens, and it's important when you're concentrating to blink fully and frequently. Otherwise, you're basically staring the whole time and your tear film evaporation is increasing. When you're outside, the patient should be educated to wear wraparound sunglasses, as traditional sunglasses provide a nice view, but they don't really keep the wind and the sun off the eyeballs themselves. Try to avoid or minimize air conditioning. Look, if you have to have air conditioning in your hot climate, you can humidify the air by placing some bowls of water or vases around the room, or considering a humidifier. Don't overheat, and use glasses or goggles when necessary. Avoid allergens, as they can exacerbate dry eye. Low allergy cosmetics exist and shampoos. Avoid smoke and, if you can, pollution. And the patient should optimize their general health. Systemic medications can contribute to or exacerbate dry eye as well, particularly antihistamines, beta blockers, antidepressants, and anti-Parkinsonian agents. As a rule, just think any anti-medication can cause dry eye. Ask them about their general health. For patients with sleep apnea, many wear masks at night to provide CPAP. And there can be leakage around these masks, and this can really dry the eyes overnight. Ask the patient if they're waking up with their eyes feeling sore. For some patients, they'll need surgery, and it's important that we consider the dry eye before their surgery. When biometry is performed, you may want to separate the surgical consult from the biometry and counsel the patient to manage their expectations. During the surgery, take steps to make sure the eye doesn't dry out and you avoid microscope light toxicity, and postoperatively, avoid preserved therapy if you need to. Intraoperatively, you can tape the lid closed after the anaesthetic is given. Keep the corneal epithelium hydrated during the surgery, and be careful with excess topical anaesthetics, as these can cause toxicity. Clean the lids if there's anterior blepharitis before you start, and avoid excess microscope light exposure. Once you finish, close the lids, particularly until the anaesthetic wears off, as they'll have reduced blinking while it's acting. Postoperatively, you want to repeat the assessments that you performed before the surgery. That was the assessments you did to establish that they had dry eye. And this will enable you to identify the features of ocular surface disease that they have and grade it. And you can use this to tell if the patient's improving during follow-up. You then follow the steps, and that's follow the steps on the step ladder. Start at the bottom with simple therapies and move up until you see results. Communicate with the patient, particularly if it's a dry eye around the time of surgery. You can reassure them that her symptoms will most likely resolve. This is a patient that was referred to me today in the clinic with gritty eyes. And when I had a look, the eye looked grossly normal. So in these sort of cases, patients with few signs, it's important to perform a careful examination to exclude any of the often missed or undiagnosed causes. And if you identify these causes, you can then target your treatment appropriately. Now, a common thing that can be missed is meibomian gland disease or any borderline dry eye disease. So look very closely at the lid margins and the glands and their secretions. So patients with dry eye symptoms may have easily missed or poorly treated diseases. So it's important to identify these. Conjunctivochalasis. This can be easily missed. Have a look at the inferior lid margin and see if you can see any conjunctival folds. Sometimes it's hard to spot, but with fluorescein, you can see it more easily. Here, with the fluorescein, you can just identify the fold of conjunctiva at the white arrowhead. Superior limbic keratoconjunctivitis. Patients with this condition often suffer with a lot of irritation. So it's important to take your time and look under the lid. Look at the superior bulbar conjunctiva. It's typically engorged, injected, and there's staining with fluorescein. In managing these patients, often topical steroids are needed, as well as increased lubrication. You may consider plugging the superior puncta, bandage contact lenses, or even resection of the superior bulbar conjunctiva. Meibomian gland dysfunction can be easily missed or untreated. Take your time and look at the lid. Look at the lid margin and press on it. How many glands are blocked? Have a look at the secretion that comes out of the glands. And corneal epithelial basement membrane dystrophy. Patients with this can have an eye that looks grossly normal. Their symptoms may be similar to dry eye disease, but check when their symptoms are worse. Typically, it'll be in the morning when they wake up or at night. So have a close look at the cornea. Some conditions that give patients dry eye-like symptoms are often undiagnosed, but if you look closely, you'll usually find some clinical signs, and this will help you manage these patients. After adenoviral infection, some patients can be left with a superficial punctate keratitis. Have a close look at the cornea for subepithelial opacities. Limbal stem cell failure can produce a whorl-like keratopathy, and this is best seen with fluorescein. Toxicity can produce both inflammation and conjunctival staining, usually on the inferior bulbar conjunctiva. Toxicity can be to contact lens solutions, non-preserved artificial tears, glaucoma medications, and the more medications you're on topically for glaucoma and the longer, the more likely you are to have ocular surface disease. Cosmetics contain preservatives and can produce toxicity. These patients will all usually have an epitheliopathy or conjunctival inflammation. Some can develop conjunctival scarring and only have intermittent inflammation. So to sum up, how do we manage dry eye? What are the principles? Well, firstly, identify that it's there and its severity using a range of tools. Back to basics, take your history examination and target investigations. Document what you find. Use this information to tailor your treatment to go up and down the step ladder and educate the patient to manage their expectations. As you go along, continue to address what needs to be treated and reassess so you can end up at the right place on your step ladder. Never forget about systemic conditions and the medications used to treat them, as these can not only cause, but they can also exacerbate dry eye. Thank you.